Hey, GP learners, welcome to this episode. We're going to be talking about the new update to the general practice contract that's come out in June, just like basically a couple of days ago. It talks about three key aspects, so the CD uplift and two new enhanced services, talking about obesity and long COVID, as well as updating you on all the various things me and Andy have been up to over the past couple of weeks and the stuff coming for you in the next couple of weeks as well. Let's tech enhance your primary care and learning. How are we doing there, Andy?
I'm pretty good, Gandhi. It's a sort of slightly overcast morning over here in my part of Nottingham. How are you doing?
Yeah, not too bad. I know we've had a little bit of a break, so our eGP learners may have wondered why we're slightly out of sync compared to what we were doing before. But yeah, it's been pretty cool. Myself and yourself are both taking a little bit of time of leave, desperately needed and stuff, and interesting to go back to the chaos that is general practice as ever. Hopefully you all enjoyed our episodes whilst we were away, and we've got loads of amazing content coming for you in the next couple of weeks, including, and I'm going to mention this now, our amazing System 1 user conference on the 30th of June. If you haven't registered for this already, absolutely must do. The content we've got for this is so on point. We just had our onboarding day yesterday with all the sponsors and speakers yesterday, didn't we, Andy?
Yeah, I spent some time with some of the sponsors and speakers yesterday, introducing them to the Hopin platform, which is actually fantastic. A really good way of recreating that experience of going to a physical conference. There's a networking area for those haphazard meetings you can have with interesting people, expo area for interesting sponsors, as well as the normal kind of stage for your keynotes and sort of breakout rooms for sessions. It does a really good job. It's worth coming along even just to experience the platform.
Absolutely. And in terms of the content, it's absolutely on point. So System 1 are really bringing some amazing things. I've had a couple of sneak peeks of what they're doing, and hopefully they'll be ready to go for the conference on the 30th, if not imminently about to be released. So you will not be disappointed if you join us for the actual event. On top of that, sponsors are bringing some amazing stuff as well in terms of things they're planning and doing. And on top of that, we're going to have all of our fun and usual games of engagement and that kind of stuff as well, some special prizes, and a couple of things that even Andy doesn't know about. So definitely make sure you join us. We'll put the links down below. But today, we're going to talk about something far more interesting, I think, in terms of the current point of view, and that's the new contract guidance from NHS England that just dropped literally a couple of days ago, explaining additional funding resources for general practice. I know GPs are taking it one way, but I think the media is taking it another, aren't they, Andy?
Yeah, do you want to bring up the Daily Mail? I know.
So we apologise for sharing the Daily Mail, but this is the only organisation that's gone down this line.
Yeah, we try to avoid it. But yeah, I actually heard about this via the Daily Mail website. Not that I'm frequently there, but they do kind of invade my life through other portals. Before I read the letter, actually. So they've. It's interesting how quickly these letters to general practice and contract variations actually make it out into the mainstream media. Actually, and often these journalists are very on the ball, and this is how we learn about these things through the headlines, which is a really odd way to have a contractual arrangement with your main commissioner, I think. So what sort of take are they taking?
You commented previously that there is this cynical view from many GPs, and potentially it may be realistic, that actually, the media is the way we get our information, not NHS England formally. So often there have been news stories that obviously been broken by the media well before even GPs know about them, and stuff, particularly things like the contract variations and stuff have been part of that. But yeah, carry on.
Yeah, they've gone in an interesting yet possibly predictable direction with this. So the headline is GPs will be paid a bonus of £11.50 for every obese patient they refer to diet plans and fitness trackers as part of NHS anti-obesity drive, which is actually pretty accurate, because that does check out with the facts of the contract variation. There's a little bit of a flavour of bonuses for GPs, which has a bit of that GP bashing flavour that they often engage in. However, the article doesn't really go in that direction, and it's more of a anti-nanny state sort of direction that the article goes in. They're very quick to jump on the BMA's comments about the contract variations, which are negative. So sort of highlighting that perhaps doctors don't want this intervention or feel that it's going to be helpful either. So they jump on that, and then they talk about how Boris Johnson has pivoted towards more nanny state approach with regards to sugar tax and nudging people's behavior in the direction of healthier lifestyles and interventions, which they disagree with, as they take a bit more of a libertarian standpoint on it. So that's really the direction that they go. But I think we just wanted to highlight it just to just to show how quickly the media jump on these things and sort of begin to take
Mhm.
their own spin. And you can have patients coming in to surgery asking you about things before you've even read the contract variation letter. Strange world.
Yeah, I mean, we're pretty quick. We're trying to review this within 2 days of the document coming out, but yeah, they're far quicker. 2 hours, I think they did it in within. But let's talk about the document itself, shall we? So, if you want to follow us online, you're welcome to check out the link, which is in the description of the YouTube video and stuff. So you're more than welcome to follow us on the document. But we're going to go through it from top to tail. It's only a few pages, which is good by NHS English standards. And we're just going to cover through the three main points that are coming through this. So the first one is the fact that NHS are going to continuing the CD uplift payments for doing the vaccination schemes. So many people in general practice and PCNs will particularly be aware of this. So because of the amount of extra workload it's created for PCNs in terms of supporting and driving through, our world-beating vaccination plan that we've got and how amazingly we've managed to vaccinate so significant proportion of the UK population, to continue to support that they are increasing the CD funding as they have done for the past 6 months, and that will continue up until
September.
September, yeah. It'll be interesting to see whether or not it gets continued again. So every time they do this, we keep saying, well, they're not going to do it again, and they have done. But I'm not sure. I think this may continue again, and the reason why I say that because October is going to put us well into flu campaign season, and obviously what the flu campaign will look like will be really interesting. I think this year round because obviously we've got seasonal flu and then we've got COVID as well, and there are obviously some rumors about potentially people needing a third booster. How that's going to work, what kind of other boosters and stuff people may potentially need. So, I'm not going to say it's going to stop this time, Andy. I don't know what you're thinking.
I'm waiting for the surprise contract variation letter with regards to flu vaccination this year.
Mhm.
I've got a feeling we might see a letter on that topic that'll do something different with regards to flu vaccination, and I think particularly if evidence emerges that sort of co-vaccination of traditional seasonal flu vaccine along with a third COVID booster, for example, would be beneficial for the
Mhm.
population, then I think we'll see some sort of different scheme. And I think that might be quite interesting for the relationship between clinical community pharmacists and GP practices,
Mhm.
and how they have traditionally been funded to provide those vaccinations,
Mhm.
placing each slightly at odds with the other to compete for patients. Be interested. I wonder if they might do something slightly different to try and encourage collaboration and do something about that competitive environment. I'm not quite sure what they'll do, but I think it might be an area of
Yeah.
action. So mark my words. Let's see.
I think flu vaccination needs an overhaul in terms of the way it's been done. I know a lot of that's been pushed into PCN level delivery this year because obviously it's part of the IAF, so the Impact Investment Fund, the targets are now taken through to that rather than individual practice targets and stuff. But like you say, how that works collaboratively with the pharmacy networks and stuff, it should do. If we want proper vaccination of our population, having a good collaboration between general practice and pharmacists rather than making it competitive is absolutely the best way to do it. But unfortunately, the 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 systems that, reconcile the amounts and the funding and everything else are designed to prevent that from happening. So hopefully we'll see a change to allow that.
Yeah, just one further point on that theme.
Mhm.
We've had quite a high level of cooperation between the community pharmacists and GP
Yeah.
practice and PCN in my area in particular,
Mhm.
around COVID vaccination. We've been working in partnership with them to deliver vaccination clinics for our local population via a specific
Mhm.
SwiftQ link, so just available for our local population. In parallel to appointments on the national booking system that were provided in those clinics. And that's worked really well. But it's really developed that relationship with the community pharmacists. And we've begun
Mhm.
to have some honest conversations about what makes us compete for flu jabs and how that actually works. And, I'm hopeful that we might be able to cooperate more than compete going forwards. So I'd be really interested to see if NHS England do something to sort of encourage that cooperation as well. It's already there a little bit with the Investment and Impact Fund flu vaccination target, which is independent of where they're
Mhm.
vaccinated. So that is designed to encourage a bit of cooperation. So I could see further developments in that area. But that's a little bit of a segue away from the main thrust of today's letter and episode.
So yeah, true. And we're going to now talk about the two additional levels of funding that we've got. So you're welcome to read the summary part, which is the first like page and a half of the letter, I think we're going to go into the deeper parts, so aren't we, Andy? But I can see there's a couple of highlighted sections that you wanted to talk about.
Oh
Again,
yeah, I've
if you want to follow us, the links are on the chat and in the descriptions and stuff, and I'll put it on screen so you can have a look as well. But the first one talks about the weight management enhanced service. So lead us through it, Andy.
Yeah. So, well, the first thing to say, so these are optional. So these two additional activities are optional. They're not requirements. That's the first thing to say. And they, between the two of them, they attract 50 million additional funding. So that's good. They're not asking people to do optional things without providing some funding to enable them to do that. And there's 20 million for the weight management intervention, and there's 30 million for a long COVID intervention. And I think they're sort of, interestingly, they link both of them with COVID. So they deliberately highlight that obesity is a risk factor for coronavirus, and then obviously long COVID is associated with coronavirus and coronavirus recovery. So this letter and intervention are very much about coronavirus and seen in response to that, which I think is interesting positioning of these interventions. So let's lead off. So
the first thing additional to say with that, Andy, if that's all right, is that these also kick off from the 1st of July, so just about 2 weeks' time. So they are rapid starts in terms of engagement and stuff with it. So that's just additional point.
Yeah, absolutely. So just taking the main details are in the annexes of the letter. So the little bit that follows the letter, and the first one deals with the weight management enhanced service. So yeah, makes that link to coronavirus, which I think is important, and it kind of re-legitimizes these discussions around weight with patients. It's another. Often it's difficult to initiate these conversations, and coronavirus is very large still in people's minds. So I think it's a good way of linking in and starting conversations. So the intervention is mainly focused on identifying patients with obesity and then referring them into an appropriate weight management service. So there's support to rebuild the practice obesity register. There's recognition that that activity will have been difficult over the last year, and then use that information and the new conversations that will be happening around obesity to refer people through to weight management programs. It's quite clear that these weight management programs don't need to be provided within the budget available for this intervention. Those are the weight management programs that should already be commissioned elsewhere within the primary care system. So this is just about identification, having a sensitive conversation around obesity, and then referral into an appropriate service, which might be informed by people's comorbidities. Interesting thing I highlighted, Gandhi, was they've redefined obesity as a BMI of greater than 27.5 for Black, Asians, and other ethnic minorities. Just to ask, if it's not too indiscreet, Gandhi, what's your BMI? Are you?
Oh, by that definition, I would be obese. Just.
I wasn't sure whether you'd answer that. You were very welcome to side swerve it, but
No. I'm just over that, so I think I'm 27.7 or something like that. My BMI. It fluctuates depending on how active I've been and stuff. But yeah, they have. And okay, so we've had a question of why have they done that. I'm assuming it's why have they reclassified it. So that's come from SS23. I'm assuming because they recognise that actually the risk factors in the Black African and Asian communities are actually significantly higher because of BMI, and actually it's recognised that BMI usage in Caucasians is different to the other ethnicities, and it has a higher risk factor, particularly, absolutely in the Asian community. Things like diabetes and heart disease seem to be a lot more prevalent, and a lot of that's is driven by diabetes. Majority of it is a lot of it down to weight as well, in terms of how much your resistance is impacted on. So I think that's the reason why they're classifying it at a slightly different level. Is that good or bad? It comes down to, I think, the actions and the resources to help, which we're going to talk about.
Yeah, I think it's evidence based, isn't it? My understanding is that the level of being overweight, the level of obesity or being overweight, at which your risk of developing type 2 diabetes, for example, increases, is different for Black and Asian ethnic minority populations compared to the Caucasian population. So I think it's an entirely evidence-driven approach, which I respect. although it's interesting that it's different. It'd be interesting to see if that raises any conversations from
I think
people.
probably also worth noting though that obesity and particularly the BMI is often not the best marker of knowing about general health as such. So obviously you can technically have a really high BMI and be a super athlete, for example, and in other parallels as well. So the BMI itself on individually is not always a good marker of health. And I think it's important we don't confuse those two aspects with how it's worked. But obviously they have to use something. They're using the BMI because it's one of the easier calculations to do.
Yeah, it's just easy, isn't it? You just have to weigh someone and know their height. So it's so easy. And you're right. At an individual level, it's going to throw up lots of false positives for people who have health challenges. But as a population level intervention, then it's probably going to be a helpful rule of thumb for identifying people who might benefit from a weight management referral.
Yeah.
And of course, it's just about identifying people for the conversations, really, isn't it? If your BMI is less than 30 or less than 27.5, then your GP surgery is, not going to go any further, not going to have those conversations. Those conversations might result in identifying that actually you're a really fit rugby player and you don't need a weight management intervention, in which case it's not going to happen. So I think as a screening tool for people who need the intervention, pretty good, or I can't think of anything better, really. So that's interesting. So shall we talk about just break it down into the requirements, because these are the things that practices will have to make sure that they do. And it breaks it down into a few components. The first one is about developing a supportive environment. So this is about making sure that everyone involved in this intervention at the practice. So for me, I think that could mean anyone from receptionists to your more experienced clinicians should have the appropriate training and skills to have sensitive conversations around lifestyle and weight management, and also that there should be protected learning time for this training. So I've just sort of highlighted this here and said, I think, and it mentions the word commissioners. So I think commissioners should be supporting time for this activity to happen, and even potentially supporting with the content of that activity. So I think we can go to our commissioners and ask for that. Gandhi, do you find these conversations generate much friction? Because there's an emphasis here on trying to, I think, increase people's skills to have these conversations without causing offense. What's your experience of these conversations at your practice?
I think inevitably it comes down to how you raise it, and recognizing the patients that you're raising this with. So, sometimes it can go really, really well, and it can be an open door to discuss other issues. If you go in the tone of, oh, well, your health issues are caused by your weight, and leave it at that, then actually, it's not a great way of doing it. So having some understanding of useful ways to approach lifestyle change with patients, I think having the education for all practice teams to do that, I think is going to be really sensible. And I like the fact that, and this is the part I really do like about this letter, it doesn't state that it's the GP that has to do this. It does focus on the fact this is a practice team and a network team approach as well. And the reason why I like that so much is because obviously one of the new roles that kicked off this year is the health and wellbeing coaches. So having their involvement and the fact that they can do some of this work, which is what they should be doing, this is what health and wellbeing coaches almost perfectly designed to do. Having them being able to do this rather than saying it's the GP that has to do everything, as unfortunately seems to be the case often. This part I really like about the letter. So, focusing on that it's a team approach and actually helping the team to understand that principle will be really good.
Yeah, just with relevance to this potential to cause offence, because I think this was sort of at the heart of some of the BMA's response to this intervention in particular. Because the danger here is that we incentivize GP surgeries to have more conversations around people's weight, where we know that it's a really difficult thing to actually change and influence and improve. And the success of some of these weight management programs, I'm sure they have a good evidence base, the individual ones, but my personal experience is that often patients don't really make progress or engage very well often. And I think, do you think there's a danger that we just have conversations that cause offense, that sort of damage our relationships, when really patients want to be talking to us about their diabetes or their hypertension or their heart disease and other things that actually they're more willing to engage with, and there's more of an opportunity there to improve their health? But we kind of spend our time focusing on this because it's incentivized, and we lose a bit of that relationship.
I think it's always possible. I think the reality is, though, with those health conditions you mentioned, we know that weight is intrinsically linked to a lot of the outcomes of those. So if you don't tackle the weight and just focus on the condition, then are you setting yourself up for an unsuccessful outcome as a result of it? Because it is part and parcel. Now how much of it is relevant, that will be based on very much on the individual patient. And hopefully, we should know our patients to some degree in such a way that we can know which ones this is an approach to take and which ones it isn't. I like the fact that they are recommending that we have training to help people understand that. So that, it's things like concepts like motivational interviewing, all that kind of stuff. Using those tactics and helping practice teams to understand those tactics can actually make it more successful. I don't know. I actually think it's a good thing. I can understand where you're coming from, though, that it could cause conflict. You know, any type of lifestyle change can cause conflict when you raise it with a patient, whether it's smoking, alcohol, weight. Caffeine use is one that I often have with patients, because actually it's something I like to talk about with them for a lot of their health issues. But it's how you raise it, it's the way you raise it, it's the tone that you use as well.
Yeah, I need to lay off those Monster energy drinks myself.
Oh god, yeah.
Um, yeah, no, I'm playing with you really, Gandhi. I think this is a good
Mhm.
intervention. I mean, there's always the opportunity for good ideas to be implemented badly in some places, and
Mhm.
I'm sure it will happen. But I think on the whole, it's good, and they're identifying that problem, right at the very
Mhm.
beginning as well. So they talk about so this, I think, is a key part here. So practices should develop and implement a protocol for the
Yeah.
identification and support of patients. So this is really the nuts and bolts of it, really, in terms of what they want us to do. So they want us to have want us to normalize conversations about weight so that we can have them in a non-offense causing way, which I think is important. Um, they want us to recognize the sensitivity of these conversations, um, ensure that all opportunities for identification of these patients are maximized. So
Mhm.
later on, they go on to say that, you don't have to have specific appointments for this. This can be embedded in routine reviews, NHS health
Yeah.
checks, medication reviews, SMRs with our clinical pharmacists,
Mhm.
perhaps social prescriber interventions. It can really be embedded in business as usual to which would help normalize these conversations because more will be happening. It'll also increase the service area um, of our efforts to identify these patients as well. So I think that's a really important point. They want us to empower patients to provide practice with information about their weight. So I think that's a green light for saying, okay, weigh yourself on your scales at home and
Mhm.
tell us, what the result is. Measure your height. That's fine. Tell us what that is. Although it does just specifically say weight rather than height there. But
Mhm.
I think we can get them to collect information. So that's really remote working friendly, I think,
Yeah.
which is really, really important because a lot of these people still can't get on the scales at their GP practice. It's important to record the BMI in their notes. So there's an element of making sure that these things are coded and maintaining and rebuilding your obesity register at
Mhm.
the practice. Um, and then we have to refer them into the appropriate service, essentially.
Mhm.
And yeah, how do you feel about that, Getty? Are the services there? Do we have the right services? Do the services have capacity to deal with the numbers of patients we might identify via this
Mhm.
incentivized approach?
I think this is part of the challenge, isn't it? So if you look at tackling obesity and some of the evidence that's around now, I'll be clear, I'm by no means an expert on obesity, apart from technically now having it according to the new guidance. Um, yeah. But I guess one of the key things that we are increasingly learning about is that the old adage of your weight is energy in versus energy out. It's not as simple as a calculation like that. It has an impact, absolutely. If you take in more calories than you burn off, your weight will naturally go up over time. There is increasing understanding that actually it's more complex than that, and it's down to a variety of other hormonal issues and things like the dead mass something or other. It's got some weird name once you get to a particular level. So obese, and particularly the significantly obese, and we're talking, BMIs 35, 40 plus kind of thing, that actually your body tries to reset itself to those particular weights. And it will take either superhuman stamina and will, the kind of things that you'd expect people like Shazam and that kind of stuff to have, to but try and break it down once you get to those super obese levels. So whilst having access to these interventions in tier two, so I think probably what is helpful for us to cover really briefly, Andy, is the difference between the types of services they're mentioning. So tier one services is kind of like your public health campaigns and simple kind of things that most people would, easily be able to access without having to have any contact with anybody else, and they should be provided by your local authorities and things. So that's information on websites, all that kind of stuff. Tier two is the more dedicated support services where it's kind of like a targeted program. Again, they should ideally be provided by your local authorities. And that can be things like commission services, such as, Slimming World, for example, using other party providers to provide educational packages for a length of time to support patients with their weight loss outcomes and that kind of stuff. Tier three is when it goes to CCGs formally and the healthcare service, and that's looking at structured multidisciplinary teams to try and support patients with weight management, and that'll be normally a clinician with specialist interest like a GP or a specialist, physiotherapists, dietitians, psychologists, all that kind of stuff, and that team approach of trying to help support the patients. And clearly that they end up being the like I said, the BMI 35, 40 plus is that kind of stuff. Apologies if I've got the number wrong. And then tier four is when you're looking at surgical options, which when you get to BMI 40 plus, to be honest, the surgical options are the only ones that actually are evidence-based to work. So that's the key issue that we have. A lot of this information focuses on tier two service provision. So that, local authority provided educational packages and stuff. And actually, when you're trying to tackle obesity, particularly the obesity that really matters, the 40 pluses and stuff, is it likely to be effective? The evidence doesn't really support that. So, yeah, I'll leave you
Yep.
with that one.
Yep. There's a problem. But what does work for weight management? I think, at an individual level, a lot of people have success stories, and I've seen it, but there's a lot of population level failure of all sorts of weight management approaches. But at least we get to drive more people through the system. We can see how this works. If this doesn't work, then we'll try a different approach in the future. But it sounds like it's grounded on sound principles. Again, how are you guys going to go about developing this protocol in your practice, or is there a role for primary care networks here, or at a city level? How do you see this playing out for you in Nottingham?
So I'm going to give you my suggestion of what people do. Now, you can clearly listen to this, you can clearly adapt it, you can clearly do what you want with it. I would suggest that locally, using our practice learning times, there needs to be a package of educational information that services the practice. Okay. So you need to educate the practice as a team and the networks themselves. So our PLTs, practice learning times, are the opportunity to do so. And if your local area doesn't have practice learning times, this is the best example of why you need them, to be honest. So that's a key thing, to have the educational and to give people the opportunity to understand the various different aspects. Next, you use that educational time to create resources, either from other areas, and the letter does state that there will be some resources being come down from the centre and stuff to support us, but making that a bit more personal in terms of the resources that you have. So the opportunity to evaluate what resources you actually have in your area, where there's some holes potentially, but then also directing that what you need to do for patients and that kind of stuff, and then creating some educational content for patients, such as like a really brief video of how to tackle weight management issues and the resources that you can support patients with if they're at particular levels and stuff. Then you send out a campaign that says, are you concerned about your weight? Here's a video that kind of talks about it so the patients can watch and engage that information, and ideally having that translated into various languages, particularly for areas like ours where we've got obviously patients with non-English speaking issues, and then tag that on at the bottom with another link that captures information like, if you are, please give us your weight and your height, and we will then support you with the relevant services to help you from that place. And that can then lead to outcomes either with sending information for tier one, tier two. If it needs something more significant, then you can involve things like your health and wellbeing coaches. You can involve other areas, or you can do direct referrals to tier two, tier three services and stuff if relevant things. And I think that mechanism, A, should fulfill the requirements of the enhanced service, and B, should really help to improve patient engagement with this and mean that we actually do something really effectively. But that's my view. What do you
Yeah,
think?
I think that sounds fantastic, Gandhi. Yeah, really excellent. I think sort of the sort of city level where people might be developing their PLT sessions is the right
Mhm,
level for this to happen. Also, PCN level is a reasonable sort of
mhm,
level to use some economies of scale to design an appropriate information, appropriate intervention. I think when it comes to developing nice packaged information for patients,
mhm.
doing that at a level bigger than an individual practice is often
Yeah,
a good use of time, and also it often
absolutely.
legitimizes that information. If you can say it's come from a group of practices,
Mhm,
then I think that provides a little bit more legitimacy that your practice isn't just singling you out because they think you might have a problem with your weight and they want their £11.50. No, this is actually part of a national campaign, and we're approaching this as a group
mhm,
within the city. And also, you can develop better quality information packets for patients. And I think some patients like video, some patients like written information, PDFs, physical flyers,
yeah,
to ask them to engage with the program. So I think that would be a good idea. And then also, I think if you're structured about this, you can make sure that the right people are doing the right work. So actually, getting the information out can sort of be the job of everybody, really. Receptionists, social prescribers, I think, can be involved in getting information out to patients. And then when the information comes in, there can be an element of triage around, okay, how bad is this person's weight problem?
mhm,
And if it's about tier 1, tier 2 interventions, then that really doesn't need to come near the clinicians, at the practice, really, because that's about signposting them to local authority interventions. But for 3 and 4, maybe that's where you really do need to be focusing on having careful conversations, and where there is um, appetite within that person to make a change, because I think that's a very important indicator of whether the intervention will be successful or whether the referral to the intervention will be successful. Where that appetite is there and the patient understands what they're signing up for, fire away, send them in, and hopefully
mhm,
we can make good use of what will be limited resources at tier 3 and tier 4.
mhm.
So I think we need to be responsible about how we use those resources.
Absolutely.
Yeah, cool. So
And it's
I
important to
think,
recognise that even accessing those services, even though they're limited, can be really challenging. So to access tier 3 services in our area requires multiple steps for the patient to have been through. It requires significant amounts of exclusion forms to be filled in from the GP practice. It's not an easy process. It's a really prolonged one that can take time. So making that side of things a lot easier would always be ideal. I guess in terms of capturing the information, it does give us some specifics in the patient support and referral aspect of things, doesn't it? About how the fact that you have to have a weight documented in the past 12 months. And I think that's possibly where the Daily Mail's picked up on some of the content and things in which we talked about, and in particular about the payment, isn't it, Andy?
yeah, so £11.50. So you were crunching some numbers, Gandhi, and you felt there
Mhm,
was a bit of a discrepancy between the amount of funding available for this intervention, 20 million,
mhm,
and the amount of money that would be required to refer all of the obese people
mhm.
to a or to fund their passage through this
Yeah,
pathway to be referred to weight management people. If you included all of the obese people in England, for
yeah.
example, so how does that break down?
Well, if you just scroll slightly up, the reason why that I'm asking that is because it's relevant to one of the things it mentions here, which is the national, what's it called? The NHS Digital Weight Management Services. So, and these are specifically for patients with obesity, with either hypertension or diabetes. And this is a new service that's going to be launched from the 1st of July. It seems like it's a digital resource, and that can have a capacity of up to 270,000 patients in this current financial year. So, from July till April 2022. And then there's other weight management services and things. And then, it talks about all the other aspects from there. So the referral is the practices will be paid £11.50 for any patient living with obesity that's then referred onto an eligible weight management services. So I'd really like clarification if that means it's the NHS digital weight management service or if it's all the other options included, because that's a distinction that would be nice to clarify. But the reason why that's relevant, so if you imagine that there's 270,000 patients that you can maximum refer across the country, 70,000 practices, 7,000 practices across the country, irrespective of the patient numbers and stuff, it doesn't really work out numbers wise in terms of accessibility. So I think that 270,000 is going to be filled up really, really quickly. And you compare that to the number of patients estimated to have obesity in the UK is approximately just under 20 million. So those numbers don't seem to rack up, and whether the provision of services has got enough capacity to deal with what they're expecting. The other thing, which is the next line, so section 11 that it talks about, it says that it's going to be using the data to evaluate this based on March 2020 data. And I'm really confused why they're not using March 21 data, which is obviously more accurate and is available. I wonder if it's down to the view that because of COVID, we don't have as much weight readings because patients have been coming in at less than what they used to the practice. So is that because we've got less capturing of data in some way? But I've not seen any evidence to back that up, because actually the weight, as you mentioned earlier, you can just ask the patient over the phone, "What's your weight?" and document it from there, which is what I've been doing loads of for many of our patients and stuff. So I'm really confused why they're using old data to evaluate the payments, yet all the targets are based on current data. There's a little bit of explanation I think that's needed there.
Yeah, I'm not quite sure either, Gandhi. I think, does it depend on how you actually populate your obesity register? I'm just speculating here,
Mhm.
but do you need to have the weight within the last 12 months in order for them to be on the obesity register? And therefore,
Don't know.
it could be the case. And therefore, I suppose whilst we would have been able to ask patients their weight over the telephone over the last
Mhm.
12 months, it's not really been a focus, I suspect.
Mhm.
So they've probably looked at the data, and they probably think that the 31st of March 2021 is bum data, I think,
Mm.
because they've probably got that data.
Maybe. But it's
They
interesting
think,
to remember that, as I said, so there's approximately just under 20 million people, according to the King's Fund data from 2019, living with obesity, okay? The funding that they've allocated this, so the 20 million pounds funding that you mentioned, if you divide that by £11.50, that's just under 1.74 million people could potentially be referred. That's what the funding will allow. And it clearly states the funding is capped, that there's no more once it's been used. So is it going to allow for, potential people? Are they saying that, only 10% of patients are actually gonna wanna do anything about their weight? Uh, uh, I don't know. That's kinda
That
what it
might
sounds
that
like.
that might be about right.
Mm,
They'll have ran some modelling, won't they? And they'll, to inform
potentially,
it.
yeah.
And they've incorporated the concept of the cap, haven't they? I guess they've
Mm,
decided that the 20 million is a reasonable amount to throw at this. They
mhm,
they've structured this letter in the contract so that it can't be above that because it's capped.
yeah.
So I think they're being responsible around
Mhm,
how they're handling this, and they're clearly making an estimate as to how many people are going to be identified and then accept and consent to a referral. But yeah, the numbers don't all stack up.
mhm,
Yeah, what do you think about this sort of capping exercise? Because it gives the flexibility, I believe, for commissioners to apply a cap on individual practices. Is this
mhm,
there, do you think, to stop some of the practices who are really, really proactive and perhaps have very proactive patients
mhm,
from gobbling up all of this resource, and perhaps if one makes an assumption, which is only an assumption, that proactive patients tend to cluster in more affluent areas,
mhm,
there's a danger that if you don't give the option to cap, that there's a transfer of funds preferentially to kind of more motivated, more
mhm.
affluent kind of patients in areas who perhaps have less health challenges anyway. So, do you think that's why the cap's there?
I'm hoping that's the reason for it, and it's nice to see some attempt at trying to create an equality aspect in terms of, an equity aspect in terms of the funding and things. So it does mention about the fact that practices will be capped on how much of the allocated funding they can use. It does also mention that if you've not used any of the level of funding by November time, so I think it's 40%. If you've not used 40% of the available options by November, then they may reallocate the funding to other places that are able to do so. So I think there is some fairness in there. I know people are going to have different views in terms of what is fair and what isn't fair, but it's nice to see some elements of it being done. So again, a nice addition from NHS England, which is refreshing to see, to be honest. But yeah, I mean, that's pretty much the payment and everything else like that. The payments will be made quarterly by commissioners. That's the last thing that I think that the letter explains. So, it is a bit of a lag time, but that's what usual for general practice, isn't it, at the moment? Everything we get paid for about 3 or 4 months after we've actually done it.
So yeah, on the whole, I think that seems like a, a
Mhm,
reasonable um, a reasonable contract, and it's probably the right time to start doing something about people's weight again as people come out of lockdown.
mhm.
And while there's still that link with COVID in people's mind, perhaps to add to the motivation to take action. So I think the
Yeah.
timing's pretty good, I think. So
Well,
the
just
next
before we
section,
go on to that, Andy, we have had a couple of comments and stuff that have
cool.
come through. So Mohan mentioned earlier about how there's been a move to using waste management. Sorry, a move to using waist measurement as a marker of ill health and obesity and stuff instead of BMI, which I think has some evidence behind it in terms of the size of your waist is a good marker of ill health in some ways. But it's also a harder one to capture because it allows a lot more user variability. Because where do you measure the waist from? Often patients may make an error in terms of that and stuff. So it's important to be aware of that. And then S23 again asked a question about the BMI aspect. So we talked about how that rugby players, for example, are commonly used the example where their BMI is potentially very high, but actually they're super fit and it's not an issue. Is there a way to exclude them? Well, it's like Andy said that if you know that they have something around them that means that they're not technically obese for a medical reason, then actually you just don't put them forward for it. But yeah, it's not really another mechanism as far as I'm aware.
Yeah, I don't think it's operating like a kind of QOF indicator with a
Mm.
numerator and denominator to determine the payments. I think it's just if for everyone you do, you get paid. It's that sort of
Mhm.
thing, which is simpler. So there's no need to exclude patients, and some patients it's just not going to be logical to put them forwards for the intervention, so that you're just automatically not going to do it for those patients.
Okay. So now we're going to talk about the long COVID enhanced service. So this is again a new service being developed to try and support the impact of particularly long COVID on patients. It's got more funding than the obesity one, which is interesting. Um, there is that difference. And it focuses a lot on some of the evidence that we have, except in fact we don't have a lot of evidence about long COVID because it's so new. And it mentions new, I think, about 3 or 4 times in this particular section as well, doesn't it, Andy?
It does, yes. So yeah, new condition, but I think NHS England are anticipating that this is going to be a big problem,
Mm.
and in terms of the sorts of numbers that I think they sort of look at give a number of about 1 million cases somewhere within this document, and also it's going to be a politically sensitive topic
Yeah.
as well. So it's going to affect a lot of people, and I think there's going to be a lot of talk about it. So I think it's important that we both do and are seen to do something about it. That's part of
Mhm.
why it's there, I think. And again, this is really about similar model to the weight intervention. This is about educating staff to have conversations and to identify patients correctly with long COVID, and then to put in place appropriate interventions, which essentially are referrals to self care, self treatment resources, and also to local long COVID clinics.
Mhm.
And there will be a requirement to commission those locally as well. So, yeah, what are your thoughts, Gandhi, about this?
Um,
Or
I think it's actually not too badly written an enhanced service in terms of what it looks like and how they're approaching it. I think the first thing to mention to those that aren't aware, so long COVID is defined as either ongoing symptoms from COVID 4 to 12 weeks post infection, or ongoing symptoms because of a syndrome that may have been caused and are continuing, and there's no other cause found for them. So obvious things that I think many patients may have experienced is the breathlessness or the loss of smell and taste and that kind of stuff and how significant they are. But actually, there are many patients who are experiencing unusual other types of symptoms like palpitations, exhaustion, and a variety of other things that potentially may have been triggered by COVID itself. Kind of mirrors up to the whole concept of things like ME and other kind of conditions that sometimes are considered to be post-viral episodes and that kind of stuff. But specifically, obviously, this is with reference to a COVID infection. Um, and I vague apologies if I have got this wrong. I'm using my memory, which is never always 100%. But I vaguely remember there's some theories around there that you don't necessarily have to have had a positive COVID test in order to be counted as long COVID. Although that is probably one of the better markers for it, because there are some patients that have repeatedly tested negative and still had unusual symptoms, which they can't find any other cause for, an assumption that it's been COVID. Um, so there is that element of things. But it does focus a lot on the NICE guidance that's come through. And again, if you want links to that, we put that in the description below, and it is under the document there, as you can see, Andy showing and stuff. So it does mention that a few times in terms of how to structure clinics and all that kind of stuff and things. Um, but it does talk about how and what they're asking us to do. So what did you get from that, Andy?
Yeah, so if we break down the requirements, so again, very similar to the weight management intervention. So there's an education component to it,
Mhm,
and they're asking us to make sure that all staff who are going to be involved in this process of identifying, assessing, referring, and supporting patients have training that is appropriate to their role
mhm,
within the system and their level of expertise. So the education that's going to be required for your social prescribers, as you said, with weight management, is going to be
mhm,
quite different to that's going to be required of your nurses and your general practitioners will be having more in-depth involvement in the clinical assessment of these patients.
mhm,
So you need to make sure that appropriate education has been delivered. So yeah, I mean, in terms of how to deliver that, this would be a fantastic topic for a protected or professional learning time
mhm.
event. This is the sort of thing that if everybody's going to be doing it because of the contract requirement in the letter, then it makes sense to do that at scale. And you can kind of pull in your secondary care specialists and have some really good quality
Mhm,
educational material and make sure that that's not just for the clinicians, but for
mhm,
other people who will be involved in identifying these patients. Also talks about sharing of learning within systems and between system partners. So I think that's definitely where primary care networks and potentially wider PLT events can have a role in terms
mhm,
of providing a forum to discuss people's experience of dealing with patients with long COVID and what is working, what isn't working, and the implementation of this letter. And then it talks about and then so once you've identified these patients, what's the intervention? Well,
mhm.
it's really signposting or referring to an appropriate intervention or part of the pathway. So initially, and for more mild cases, that might be signposting to the Your COVID Recovery website. Have you had a look at that, Gandhi? I've not been there. I'm assuming it's up
Very
and
briefly, it's got a nice collection of
running.
resources and stuff and information. So yeah, it's a good place to start, I think.
Yeah, good. And then if patients still are not making progress and are significantly affected by their symptoms, then a referral to the local long COVID clinic, post COVID assessment clinic,
Mhm,
whatever they are going to be labelled in your area, is the other intervention. So that's essentially what they're asking us to do, which at face value isn't too much, but
mhm.
they're anticipating a large number of patients with this syndrome.
Yeah.
So it may actually amount to quite a lot of work coming through practices. So I think it's good that it's being funded. The coding section
Mhm.
actually is the best way to break down what it wants you to do. I
Yeah.
think it talks about, right, we need to diagnose these patients. So we're going to have to identify and have conversations about them.
Mhm.
We're going to have to signpost them or refer them. And it gives us it tells us there are codes that we can use for that. And then, of course, they'll be interested to know if patients are resolved. So we
Yeah.
should be applying resolution codes where we know that their long COVID has resolved.
Mhm.
And that's really what we're going to do. I mean, was there anything you wanted to say before we get on to the assurance and payment around this intervention,
Um,
Gandhi?
so I'm happy to share what I would suggest to be a plan for people if you wanted. I can give you the
Gandhi's
gold
plan.
standard solution, yeah, again. Part of this comes down to doing a little bit of work about researching and auditing kind of the situation you've got. So how awesome would it be if you created a audit-based template that or protocol that basically went through your system, checked for patients with a positive test for COVID, and then check that have they, the prompt or something like that to remind you that 4 to 12 weeks afterwards to have a contact with that patient just to ask how you're getting on. And that could be either automated through a text messaging system like one of the Flories or various other things that systems may use or an e-consult. And then you can feed back information if they're, having still ongoing symptoms, either direction to the Your COVID website or, do you need a further discussion? You could outsource that to other parts of your team, for example, like the social link workers, to then review those kind of informations and things. And if they are having significant clinical symptoms, they're directed to a clinician to deal with their health issues. Whereas if it's more, occupational health, social aspects, all those kind of impacts and stuff, obviously social link workers, OTs, that kind of resources and things. and all built around a template that potentially you've got running in your system, potentially provided by, I'm going to name drop a couple of places here, things like Ardens and Primary Care IT, who happen to be sponsor of our System One Facebook user group conference and stuff. But having that kind of structured template to input the information to make the clinicians and the practice life easy, so that everyone knows what codes to use, so you don't get any issues with the coding and that kind of stuff. You can use obviously things like F12, which is what we use in Nottingham and that kind of stuff. And you've got a process there, haven't you? And all that's backed up by an educational process, like you mentioned, in something like a PLT, which is, again, a reason why we need practice learning times and stuff across the areas beforehand to educate the practice teams on what kind of symptoms and issues to look out for with the patients in majority. Boom.
Good. Gandhi, so I like your solution. I think I'll probably be doing something similar. I'm going to put my devil's advocate horns on for a second.
Go for this.
So the contract variation is different to the obesity intervention in terms of payment is not directly linked to the identification and referral of cases in this instance. Although when we talk about payment, we'll see that there probably will be an element of assurance which involves data collection of activity based on these codes from practices. So we need to be aware that practices need to do enough. So because so we're not necessarily paid for every event or person that we put through a system. There is a danger that this is potentially slightly controversial, but I know a lot of people will be talking about the potential for over-identification of patients with long COVID and mislabeling of patients potentially with long COVID, which might actually affect their perception of their health going forwards and their recovery potential going forwards, because there will be no positive test for long COVID. A positive test for having had COVID will be supportive of a diagnosis, but diagnosis won't be conditional on that. And a lot of people with positive tests may not have long COVID. And the sorts of symptoms there are actually quite broad, and they are self-reported. So I know people would be concerned that we could, if we were very proactive about seeking to label patients with this label, because perhaps we felt, particularly if we were being paid for it, but even not if we felt we're being judged on our performance on this measure, we could potentially do harm to patients by giving them an inappropriate label that makes them adopt different health behaviors to those that they would if they didn't have the label. So some people might advocate a position which is less proactive, but doing a really, really good job if patients do come forwards with symptoms that really are consistent, but perhaps placing the onus on patients to tell us when they're having difficulty. I don't know. What would you say to that sort of challenge? What do you think?
I think over-medicalization is absolutely a challenge that we all currently face, and that links in with over-diagnosis, that links in with over-prescribing and polypharmacy and all the other aspects. So you're right, we have to be cautious not to overdo this, because actually is that then creating more harm in the future for those both individual patients and the population as a whole. I think clearly what I suggested can be tailored to how you want to use it. So it could just simply be a reminder to the clinician the next time they have a contact, is this something that's relevant? And if it is, you carry on down a pathway. If it's not, then you just it's just that aid memoir to help you think, do I need to consider long COVID in this particular patient? And that'll be varying. So if you've got a patient that has no active symptoms, 6 weeks down the line, okay, fine, sorted. If you've got a patient that actually keeps presenting to the practice multiple times because they've got breathlessness, because they've got palpitations and that kind of stuff, having that reminder say, actually, could this have been triggered by COVID, and do we need to approach this in a different way? Do we need to consider other conditions that are potentially linked with that? So the vascular issues and stuff we obviously know more and more about in terms of how COVID affects it. Does that help to mean that we get a better resolution for that individual patient? Maybe. I don't know. What I like about this one is it's focused on the education and the awareness of the issues. Obviously, what the outcome is after that point, there's less of a focus on in terms of necessarily having, targets to hit, which I think is the important thing. It's more just making sure the data's as right as it could be. But you're right, we may always get it wrong. That's unfortunately the challenge with it, isn't it?
I think it's a grey area, and I think actually the positioning of NHS England on this is right, in my opinion, because it's a new diagnosis. We're not quite sure what having this label means,
Yeah.
for patients going forwards, or whether we have effective interventions that we can
Mhm.
apply to people with this label. But we know it's going to be a big problem and it's going to be important. So I think the positioning around around education, and particularly identifying and helping those people where they definitely have a need is right at this stage. And I think this reads in a way that I think NHS England are going to keep their eye on this, and
Yeah.
they'll dial up or dial down, the level of interventions around this condition as we
Mhm.
move forwards. So yeah, so I suppose the final thing to talk about is assurance and payment. So
Mhm.
in terms of assurance, at this stage, all they're asking us actually to do is, whilst they're providing us with codes, I think we should do that. They're just asking us to do a self-assessment about where the practice feels they sit and what the practice has done
Mhm.
to meet these requirements, and that's all they're really asking from
Kind of
practices in
comes
order
across
to
as like
receive.
the, QoF QI kind of process in some way. So it's just asking for a report at the towards the end of the year saying what you've done, how have you tackled the issues, what changes have you put in place, and are you recording the data accurately? So it really does seem to link up to the QoF QI work that we're doing. Interesting part about the funding, so we mentioned it's 30 million that they've allocated for this. If you divide that by the population sizes and various different things, an average PCN of 50,000 patients can expect to earn approximately £24,000 in total. However, only 75% of that's going to be paid initially, and the remaining 25% will be paid on completion. So it's not an insignificant amount of support and funding to drive this. And I think out of the two enhanced services that they're suggesting, the long COVID one to me seems like the more sensible one for practices and networks to engage in. And definitely from a network perspective, I would recommend doing this rather than from an individual practice perspective. Because I think, like you said, you're more likely to have economies of scale to support you to do that. Um, yeah, it'd be interesting to see if anybody thinks that we've missed something in this because, often we see enhanced services with massive potential holes and stuff with it. I'm not seeing any major ones with the long COVID one in terms of, it seems to be a win-win for majority of people, apart from the fact it's just additional workload, but it's workload that does have some funding with it. So, you know, doesn't seem like it's the worst in the world, to be honest, compared to some of the other things we've had.
And it's optional,
Mhm.
although there might be some judgment on those practices that don't take action on it, but it is technically optional.
Mhm.
Another thing I would say is so that the funding is to practices, but a
Mhm.
lot of where we've talked about these things would be best delivered, we've talked about PCNs and
Mhm.
even wider networks of practices who perhaps share practice uh, learning time, um, and but that's not where the funding is
No.
focused. So I think that's interesting because I think there'll be a push for primary care networks to help with a lot of this stuff, and I think a lot of them won't be able to resist. And it's the right level to design an intervention and an approach
Mhm.
that will be consistent across a community. But the funding isn't going to go to primary care networks; it's going to go to practices. So I think
Mhm.
that's interesting. It'd be interesting to know if anybody is able to square that circle. Will practices pay primary care networks to do some of this work and have a transfer of funding?
Mhm.
Or not? Interesting question.
I mean, you're right. It makes a lot more sense to have one learning session across multiple practices than each individual practice in a given area doing their own things because you just have the economy of scale in terms of doing that. How you then have an additional element, I guess, potentially looking at the outcomes and the individual actions your practice or your area may want to take. Obviously, that's a little bit more additional from that point. But I just think that, this is something that could work really well from a network perspective. But you're right that the funding will go to the practice as it should do for any enhanced service and stuff. So making sure they're being remunerated for their time and the work that they're doing and stuff. But yeah, it'd be interesting to see how practices take it, and more importantly, how clinicians and CDs are going to be approaching this with their practices because they've got really short time to get involved and stuff. So I know we've got a network meeting on Thursday, so I'll be raising this at that point. Obviously, our declaration, both me and Andy are clinical directors of PCNs and stuff, so also we're talking it potentially from that viewpoint as well. But I think it's going to be a really interesting area and stuff.
Yeah, that was really helpful, and hopefully it's been helpful for
Mhm.
the viewers and listeners to go a little bit deep on some of these policy documents. I know that's been a lot of what we've been doing recently.
Mhm.
But I find making the videos really, really helpful, and
Yeah.
watching them as well. So hopefully people have found that useful to get up to speed with the letter while they've been doing their
Mhm.
ironing or going for their jog or whatever they've been up to while they've been listening to us.
Mhm. So if you do have any questions, feel free to chuck them in the chat. I know we've got some other live viewers joining us and stuff, and more than happy to try and answer what we can. Just whilst we wait to see if we do get any further questions and stuff come in. S23 again mentioned about my kind of thing that I talk a lot about is caffeine use and stuff. Can you actually code caffeine intake? I don't think you can actually. I've not seen a code for it. I just tend to raise it with discussions, and it's particularly with patients with sleep issues. I find it a real problem. And those with bladder issues, particularly frequency and stuff. Working in inner city Nottingham, the number of patients who come to me saying, "Oh, I'm peeing all the time and wake up at night to pee," when I actually count how many cups of tea and coffee they have, I'm like, "Well, yeah, about 6 times the amount I do." So that might be why you're having problems. Do we need to look at that and stuff? But hey,
I can certainly support your assumption there around that correlation.
mm-hmm.
Yeah, if I hit the coffee, I have to sometimes interrupt meetings to go to the toilet. Those people who work closely with me will be aware of that
Join
behaviour
us
and
working those
quirk of mine.
Andy. Hey ho. So thank you everybody for your time. We hope you really enjoyed this stream and this type of content. As Andy mentioned, we've kind of tended towards doing more of these reviews of the documentation and the kind of information we get from NHS England and other resources and stuff to try and help explain these to you as part of our live sessions, as well as kind of update you all the changes that are happening in general practice. That's kind of why we do these digital primary care updates for the Podblast and stuff. Next week we're going to be giving us some of our recorded content. So in particular, it's likely to be a supporting tool for our conference, just because that's a few days afterwards. Again, if you want to join us for the System One Facebook users group, definitely sign up. It's going to be absolutely amazing. I'm so looking forward to this one, if I'm being honest. I'm working really hard with our partners and stuff to make sure this is an amazing, amazing conference. And I really genuinely believe the content from this is going to absolutely change people's way that they do things in practice and stuff. So I'm trying my best not to give away too many information and stuff. But it's going to be awesome.
Yeah, System One have been really great with some of the innovations, so far in the last 6 months that are really going to help us work in a remote fashion, doing more in a digital way. And I'm excited to learn what more is to come from System One
Yeah,
at
so
the
I guess
conference.
just to give some of those headline topics, so there's going to be a massive update for the communication annex and information about that, which has been real game changing, I know, for many practices. The link booking stuff, so how you can help support patients booking automatically into appointments and things. Use of AirMid and patient engagement. They've got information to come from that. Looking at how you can use System One more effectively from PCN and ICS levels as well, and mobile working. And if they have got this ready for the conference, I think we're going to have some really, really happy people out there in terms of the way that they can support with additional ways of using System One from practice teams and that kind of stuff. And that's just the System One content. We've got Dan's top tips as usual. They're amazing. For those that don't know Dan, he's one of our System One Facebook user group members. It basically is my guru for how to use System One. So and his top tip session is always, if it was a physical room, I'm pretty sure it'd be standing room only. But thankfully it's not, so you can jump in and join in. I'm doing a session for once, which is going to be weird. I'm going to give my shortcuts, so how to use System One more effectively. And we've also got some other community-based things as well. And then, as I said, we've got loads of content from our sponsors that is designed to try and make your life easier using System One in general practice and just generally working in general practice as well. So it'll be a really, 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 really good event.
So how do they sign up, Gandhi? Where do they go?
So I'll put the link. See, I've forgotten to put the link, haven't I?
You not got it ready.
I've not got it ready. I've failed myself on this particular thing, haven't I? This time, Andy.
Never mind. Show notes.
But I will put it in the show notes.
It'll definitely be in the show notes.
Absolutely, it will definitely be in the show notes, so you can link up from there. I'll put it in the comments shortly as well, and just so that people can then get access to it and think. In fact, here we go. Let's do that now. So first, it's into the comments. There we go, and it is a banner. Let's stick it in right now. There we go. So, and you can see it coming up on the screen and things. So if you do want to join us, feel free to do so. I guarantee you will not regret it. And if you can't make the whole thing, not a problem. we have the recordings for you, yeah, and you will be able to access them for free as well once you've registered. So do make sure you jump in and join us and stuff, and we will promise you're going to have an amazing conference experience and the opportunity to win some prizes as well. Because you know what, that's how we roll. So Andy, we are going to be back again live in a couple of weeks' time. Hope everybody has a great time in the meantime. And as always, if you do have any comments or questions, feel free to let us know. More than happy to try and answer them as best as we can and stuff. And as always, in eGPlearning, we're here to help tech enhance your primary care and learning. We'll catch you in the next episode.